Good afternoon. On behalf of the American Hospital Association, welcome to our leadership scan on workforce recovery, what's working and why. This presentation and discussion are brought to you through the generous support of Unitek Learning. Today's event will share scalable solutions to healthcare staffing challenges. Hospital leaders from clinical ops and workforce development will share collaborative models that reduce vacancies, support employee success, and improve readiness, contributing to a broader dialogue on workforce recovery and regional alignment. We've allocated some time for your questions, so feel free to submit questions through the Q&A portal at any time. Also note, links to the webinar replay and the presentation will be included in your thank you email that will go out tomorrow. Now let me introduce our session panelists. Laura Ratschliger is Vice President of Nursing Operations and Virtual Nursing at Advocate Health. Rachel Culpepper is Director of Clinical Operations at Indiana University Health West Hospital. Caitlin Masterson is Senior Vice President of Workforce Development at Unitek Learning. And our AHA moderator today is Elisa Pacochaga, Group Vice President of Clinical Affairs and Workforce at the American Hospital Association. Now I'll turn the call over to Elisa to begin the panel discussion.
All right, thank you so much, Jennifer. Appreciate you getting us set up, and I'm excited for this conversation. We have three leaders who are on the ground and nationally looking at solutions and opportunities to address workforce and particularly nurse staffing challenges that have been with us for a little while. They have a lot of, we're not going to admire the problem any further. You all know and are probably personally feeling a lot of those challenges. They're going to talk about some of the solutions they've been able to come up with and some of the ways that they are addressing these challenges in their organization. So I'm just going to jump right in with some questions. As Jennifer mentioned, you can include your questions in the Q&A box and I can ask them as we go or at the end of the session as we move forward. So let me start out, and Laura, I'm going to direct this to you first and then over to Rachel. But what would you describe, if you had to pick, this most significant one or two workforce challenges your organization faces today as a nursing leader, and how is that impacting operations?
Oh, Lisa, that's such a great question. I do want to take a different spin on this because I think our people are the most important of any organization. And I think that if we're not taking care of our leaders, which we can see leadership turnover, you know, the AONL just came up, span of control and nurse well-being white paper. I think that certainly is one of our most significant challenges. And I say that in particular because without a leader, everything else in your department, your hospital, your organization goes out the window. You know, all your strategies in terms of new execution, your strategic plan, anything new, forget the innovative strategies because you don't have a leader. So I want to talk a little bit about what we've done at Advocate Health in terms of how we've created different solutions. We have a manager relief program, which I'll talk a little bit about in a minute, but the technology as well as data and analytics, everything we're doing from predictive AI scheduling tools to make the lives of our leaders better, and also about anything we can do with well-being. So back in 2021 at Advocate Health, we launched a leader relief program, which really not only supported the leadership development and then trickled to teammates, but also provided hospital leaders some burden support in a relief backfilling into their position, if you will, a float pool manager that's coming in to help, which then in turn helps the teammates. And then they're also sharing best practices as a consultant. So since 2021, we've supported over 50 departments. We've promoted over 8 of the leaders in this continuous pipeline to support the teammates. And we've had about a 30% reduction in the nurse manager burden, as well as a 30% engagement just by engaging our leaders differently at Advocate Health. So great question.
I love those, both the numbers and the idea of a floating manager. In general, managers tend to be the ones who are body blocking the, the schedule, putting themselves in and filling in and, don't necessarily have that relief valve. So I love the idea of realizing they need as much support as the rest of the team in terms of relief. Rachel, let me turn to you. And as an AONL board member in Region 5, I'm sure you have both that perspective nationally, but then what's happening on the ground at your organization.
Yeah, absolutely. This question I feel like is a huge umbrella question to many of the challenges that we face in healthcare. But when I think of what we need to do to solve for the pipeline of our workforce, my mind instantly goes back to the nursing schools and how we need to advocate consistently for that funding not to be cut, to continue receiving funding, because I think our shortage does start with the shortage of our nursing faculty. As we know, we have many students year over year. In fact, the last data I heard, though, we actually declined in the amount of students we are turning away from nursing schools, which is great, but we have a ways to go, and we have a vacancy that is tremendous. In one of my nursing units, we have about 15 posted FTE positions, and only last month we're able to fill 2.7 FTEs. So we are not close to meeting the demand. So my mind goes straight to the nursing faculty and how we can leverage our federal government to make sure that we can continue to have that funding. The other thing is, I think there's several ways that we need to look at retention. And so I'll probably cover a little bit more in the following questions around retention, but we gotta keep the people that we have in our environment, or otherwise this is gonna be a perpetual problem.
Absolutely, absolutely agree. And I think there's a lot of opportunity. We are still, I don't remember the number off the top of my head, but I know it was north of 20,000 applications turned away. So certainly there's a lot of interest still in people want to be nurses, people want to go to nursing school. So how can we make sure that we can make that as available as possible? And Caitlin, I'm going to bring you in here since this is where this line went, since this is what Unitek does. So what are you seeing at a national level in terms of really being able to open up that pipeline of folks who want to go to nursing school, but we just don't have the faculty and the clinical placements, which are the two things that come up?
Sure, great question. Unitek's been in nursing education for over 30 years, but in the past 5 years, we've stood up a separate division within our organization called our Workforce Solutions Division. It was built just for hospitals. I think we've implemented what we call School in a Box. So we run BSN, ADN, LPN programs embedded directly inside of hospitals, built entirely around their staffing model and employees. There's two problems that if you actually pair them together, it ends up being a solution. So one of them, of course, don't want to belabor the point, nursing vacancies, shortages, premium labor, recruitment costs for hospitals are a huge strain. But then there's the other, which is really the missing bridge between entry-level roles and professional practice. So there are people wanting to be nurses who access is the issue. I think 75% of employees want to pursue more education, but only 54% have access, and fewer than 40% actually use their tuition benefits. So to me, our division really came to be to help bridge those two things together as a solution. The intent is to make education part of the hospital's workforce strategy, not just a benefit or like a passive perk. This is an intentional staffing plan, a way for hospitals to grow their own, stabilize costs, build long-term retention. It's always really encouraging to me when we partner up with hospitals, we survey their employees, and we learn just how many people want to be nurses. So these programs are incredibly important to really future proofing your workforce and bringing down vacancies.
Yeah. And I know I really like the idea that you partner with the hospitals, because one of the challenges, and I know both Rachel and Laura could probably expound on this at length, but this, in most cases, it's, oh, well, now you have to stop working and go to school full time, or go to school most of your time. And it's really, really hard to do that if you are working full time and have a family and all of those things. So, I'm going to come back. I'm going to change up my order a little bit. Want to talk a little bit about some of the workforce development programs you have implemented. And I'm actually going to come back to Laura for a second, because I know we've gotten a question about your leader relief program and sort of how you budgeted for some of those challenges. So let me start with you there.
Oh, I love that question. That's one that I always anticipate when we talk about that, because in healthcare, gosh, aren't we driven to do everything budget neutral? And the program was budget neutral. What we did was we charged the salary and benefits to the unit that is receiving the leader relief. So at 70 hospitals, you can imagine that, we certainly need a great deal of FTEs to be able to support this. And so when I proposed this back in 2021, that was one of the key contributions, is that it would be budget neutral. And so we work with finance to ship them on the back end. And then, of course, there is a little bit of overlap with great intention, because we want this leader to mentor the new leader that's coming. So there is about 2 weeks that you could argue that the salary is duplicative, but overall, the grand scheme of things, it is budget neutral, because we charge them on the back end, just like a float pool would. Great question.
All right, Rachel, let me come to you and talk a little bit about some of the development programs that you've put together to really keep people. I know you've done a lot of work, particularly around mentorship and ways to keep people in the building, because in addition to needing to bring them in, we need to keep the ones we have. And what is really essential to making something like that work?
Yeah, so we at IU Health West Hospital have done quite a bit. And so I want to also preface that this was a group effort by many directors, not just myself, but we all support each other in this work. One thing that our nursing professional development coordinators do exceptionally well at is a transition to practice, which we are transitioning to nurse residency as our title for that. And that really supports the nurses from orientation to first year. And they have several people, the same cohort, so they build relationships with their cohort, and so that has proven to be able to, so you can have a buddy that's also experiencing like the transitions from orientation to being an expert clinical nurse. So that is one program that has been really beneficial for us, and our chief nursing officer has supported that in ways that we are saying that is mandatory, and that is a part of their time. And so leaders must help get them there, unless there's an extenuating circumstance, of course, that brings them away from that. But that isn't that is a mandatory, so it's not an option for them to not attend. And that is for anybody who comes into our environment with less than 1 year. So that has been very, very a great program that has led us to a few other different strategies as well. The next one that we do is we have developed a leadership framework that is different from a few years past. So we have what's called clinical advisors, and those are nurses that also elbow to elbow support with these nurses who don't have much experience. And so therefore, even after orientation, they have a built-in mentor. They have somebody who is also looking at their practice and helping them fine-tune their practice as a bedside leader or as a bedside nurse. And we found that to be most beneficial in the emergency department. And that is one of the areas that I oversee. And our clinical advisor there was one of the first ones. So he was actually able to help us build this structure in other departments within our facility. And we showed a really positive increase in our retention by 10%, which is a lot when everybody counts. And so that was a huge benefit. We've also seen a lot of clinical experts rising up to the top because he mentors them. And last but not least, something I heard through the American Organization for Nursing Leadership's learning community is some people are doing virtual mentorship. So there's a nurse, we hear virtual nursing all the time, same concept, just used a little bit differently, and where you can call in a nurse who is working from home, but there to help go over a clinical assessment, or, hey, remind me how the heparin drip protocol is working, and then they can, or how the protocol is, and then they can help guide that nurse who is less experienced through the proper steps. So I thought that was a really good way to not only support the frontline teams, but then maybe give some reprieve to other experienced nurses who might need a shift away from the bedside.
Yeah, I love that approach. And I love the idea, given that in most cases, the newest nurses may get maybe working over the weekend at night when there are fewer other colleagues they can call upon to say, okay, I know this, but let me just double check it, because this is a human I am taking care of, and I want to do it as best as possible. So, Laura, let me have you talk a little bit. I mean, Advocate was a leader in virtual nursing. You did it before I even knew what it meant. So how have you been using that? Particularly, I love the way you use it as a retention tool to keep that team, especially that experienced team, at the bedside and involved in the care.
Oh, that's a great question. Yes, we are. So we have two different models for virtual nursing. One is a co-care model, which is 24/7 behind the cameras. And absolutely, we have that nurse as a mentorship, particularly off shifts and weekends. And we have admissions and discharges, probably like many organizations across the country. But one particular strategy that we've done at Advocate Health is we have coined this a 2-1 model, which means that they spend 2 days in a unit in a given area that they support, hired into a site-based hospital unit, and then they come to virtual nursing for 1 day of the week, which has really reduced turnover and vacancy up to 60% in some areas. Certainly lots of other great performance metrics to share, but in terms of retention, these nurses are loving the program, really looking at the care delivery model differently. And they're able to bring that experience behind the camera, not only for the patients, but for their colleagues that they support. And the patients that have maybe saw them yesterday in the unit are now seeing their virtual nurse behind the camera. And so we've seen some great success with turnover and vacancy related to those rotations.
Love that. I love that approach. Caitlin, let me ask you how things like virtual nursing, which, I mean, I know we've had the capability, but 5 years ago, nobody was teaching virtual nursing because it wasn't a thing we were doing on a regular basis. How are you adapting to some of these technologies, and how are you working with the organizations you're working with to build that into some of the education, given what Rachel and Laura just talked about?
Sure, great question. So, what's exciting about building a hospital-based cohort is that you're really able to sit down before the program even starts and understand a holistic view on where the hospital's going in the next 5 years, what's important to them. We can sit down and understand how onboarding's going, what your residency looks like, any care model shifts, any growth, new towers, that kind of a thing, and begin to then figure out how we can enhance the curriculum to meet those needs. Build in, instead of looking kind of to the right of graduation, which is residency and upskilling, we look to the left, and what can we do inside of the program to really make sure that these cohorts are ready for practice in the way that the hospital needs them to be. And the nice part is we have 25 hospital-based cohorts up and running today, and they're filled with 100% employees. And so it's really exciting for me to think about, wow, everyone's already in the system, in the culture, they hear what's going on, and now they're training to be a nurse, which I do think adds some extra firepower to them hitting the floor ready to go.
Love that. Love that. All right. And I'm going to come straight back to you, Caitlin, a little bit about how some of these collaborations, and particularly cross-sector collaborations, are supporting these strategies. And then I'm going to ask Rachel and Laura in that order to chime in. But how you're really using the full spectrum of healthcare, because yes, you're focused on nursing, all of you, but you need everybody in across the board. You need all the different professions that are involved. So how are you working across the various sectors to pull everyone together to build these programs?
Sure. So one of the first things I ask hospitals are, do you use like a centralized or a decentralized workforce planning model? And oftentimes I hear it's decentralized. You have nursing solving their own nursing problems in a vertical. You have it's all segmented. And so it's hard to understand how you can solve your own problems from within if you don't take that holistic view. So our employee base that are in our nursing programs today is a testament to exactly the results of looking across the aisle. We have not just CNAs and MAs, but we also have professional career changers. We have case managers, techs, we have people from compliance enrolled in the program. Imagine how that actually forms your future workforce in nursing. What's most powerful to me is what employees say. Um, Almost all of our testimonials are, I work alongside of nursing. I love nurses, the impact they make, what they do for patients. I want to be one, but access has been a problem. So with my employer's support, I'm able to really go through a program that they otherwise really wouldn't be able to tap into if it wasn't connected to their employer and supported to their employer. So for me, it's really about bringing that centralized view of the entire hospital together and not just looking 1 year out. You've got to look 5, 10 years out, especially with the stats we all know about retirements and promotions into nurse practitioner space. You've got to have that longer view.
Yeah, no, absolutely. And Rachel, I'm going to come to you to talk about how you're doing some of that. I know one of your board colleagues said to me at one point, we just are going to have to accept that we're getting these nurses for 5 years and figure out how to just create a job that they can do for 5 years, and then they're going to go do something else. And we're just going to have to accept it. And in her very firm style, but what are you doing to make sure that you're pulling across the entire organization and, not just looking at nursing, you're looking at how can we address this challenge across the organization?
I think this is another question that is a big one, right? And I don't know that anyone's doing it well right now, but it is something that we try to make sure that we're involving every discipline when we're talking about doing any care model changes or how we're going to support the understaffed areas with maybe another staffed area, and floating and all of that. So I don't know that at my organization we're doing it like we have the magic key that makes it better. But one thing we are very intentional about is taking a look around, and our CNO often says look at it differently, and even like does that because we do need to do it together. And I think oftentimes nurses, and I even find myself still doing it, I'm like, well, this is one department, here's my other department, and here's the problem we're going to solve. But we know that staffing is fluid and that we are going to have to make sure that we're collaborating with our sister units, because we're all going to support each other at the end of the day. And we do that every day. We have a staffing call. Sometimes we can say, nope, we're all good. But if there is one unit who has 2 nurses on and they need 5, then we all come together to solve that. But the other thing we need to do is, when we keep saying like we've got to change the model of care, we've got to lean on the other disciplines, such as like, well, how can our physical therapy colleagues or our respiratory therapy colleagues help us in designing what the future of patient care is going to look like? And sometimes I think as nurses, we tend to own that, which we do own a lot of it, right? Like we are the experts in our patients. We're with them the longest throughout the day. But what are some of those other tasks, those other assessments that we can lean on our colleagues for? And then the other professionals we often leave out is the physicians. Like we have to involve them because they are a major part of how care is delivered, but we often forget to bring them alongside us. And so we have to make sure that we pause and take a really fine look at our stakeholders in each of these meetings or brainstorming sessions.
Absolutely. Laura, let me turn to you. I know you're one of the examples I always share during the pandemic when you brought in the exercise physiologists, which I just think is brilliant, to help your nurses be able to mobilize patients. But what are some of the other ways that you're making sure to keep that going of like, hey, can we look at this instead of this way? And who are the other people in the organization who could be engaged in the work we're doing?
Oh, I love this because I do think that it's about creating that culture with being okay with shifting and being flexible and nimble. Certainly we have some guardrails in healthcare, of course, and due to licensing and state regulations and all of those great things that keep us, the healthcare organizations in line. But really being okay and constantly innovating. At Advocate Health, sure, we have lots of programs and without our workforce platform like youth apprentices and externs and career letters and all of those things that I know many of our organizations have together. But we do also have an aspiring leader nursing program where we actually will pay them to go to school for up to 20 hours. So I think that that's a different, unique pipeline program. And the way that it was started was actually through a grant. So I think, as you think about reinventing, think about those local grants that might be available to fund some of these programs. We've done that. We did that with virtual nursing in a rural facility where we got a $1.5 million grant to support the expansion. But also looking at your community is really key, because in one area in South Chicago, we had an LPN school. And you think LPNs certainly have come full circle and are more popular in some facilities versus others, but we created LPN externships. So it was reinventing something that had already been in place, but we noticed that that pipeline was able to come through in a particular community. Another example I can give you is that we had coined through care redesign clinical operations techs, which are non-clinical roles supporting clinical areas. And so the intent of that is to bring in entry-level talent similar to the exercise physiologies, where you're bringing it in, they're able to experience and immerse into that culture, and hopefully, of course, go through the different clinical pathways of registered nurse and so on. Really, whatever their interest lies at Advocate Health, will certainly reimburse them to go to school. So I just really think, transcending all boundaries, being really creative and looking at your communities is really key to establish your workforce needs.
Absolutely, absolutely. I keep lamenting the fact that the candy striper, including my very cute apron, are no longer as relevant. Obviously, still plenty of volunteers in hospitals and health systems, but that role as a teenager to be in the organization and really learning what it meant to take care of another human is something that I will always treasure, but is something that I don't know that we give enough people that opportunity. So I love that this is one of the ways to do that. And as Caitlin has talked about, employees who are in the hospital who may be working in completely non-clinical roles, but get to see it every day and really want to explore that. I'm going to ask one of the questions that came in the chat, and Rachel, I'll start with you. A little bit about how and if you are working AI into your models of care. I know it's a discussion we've had on the learning community, and we've gotten to see some really advanced use of AI to support ambient listening for nurses and various other things. But how are you doing? And then Laura, I'll ask you to jump in.
Yeah, so we are just on probably the edge of dipping our toe into that right now, but yet there's tons of great learnings through the learning community from healthcare systems across the nation. That's a good repository to look into. One thing I will add is that myself and a researcher are going to be doing a research project on staffing specifically and the workflows of our nurses, and that hopefully will inform some will lead to a grant to inform some of the work on maybe a potential AI solution for that. So I don't have a direct experience in that quite yet. We are transitioning to a new EMR in the next 2 years. So I think that will open some really good gates for us to be able to dip our toe into that. But I'll turn it to Laura. She might have a better example.
Yeah, no, Rachel, those are great examples. I'll just say that in terms of a workforce care delivery platform, we are piloting and testing something called Project Nursing, which is true ambient technology to help alleviate some of those cognitive workload burdens from our bedside clinicians, as well as embedding it into our virtual nursing platforms that we have. So our virtual nurses are currently working through what that will look like in terms of execution in 2026. And then in terms of a staff and scheduling platform, we're working on a plan for predictive, not only analytics and scheduling, but also fill rates. So ensuring that the schedules are certainly using true AI to help fill our needs and help support sending those to our clinicians in real time. Certainly much different than we've seen in the last 10 years, because I think we've all seen different buzzwords of how this is going to help, but true predictive AI that are helping to do the schedules for not only our clinicians, but our managers that are certainly the ones that are bearing a lot of that burden.
I think everyone's going to appreciate not having to spend more time with an Excel spreadsheet. Caitlin, let me bring you into this discussion, because I'm sure AI is coming up in, as you have these conversations, you're building curriculum. How do you even build curriculum for a program for something that is going to change by the time you put pen to paper? It shows how old school I am, putting pen to paper, right? But what are the ways that you're thinking about with your hospital partners bringing AI into this work?
Sure. So, I mean, I think AI elevates all roles. I've heard nurses say it allows them, instead of having to take notes and worry about all of the things, they can look their patients in the eye again and communicate more smoothly. So that gets me excited, and that makes me think about culture. So when we're working with hospital partners, one of the questions we're asking is just, do they have an AI project charter? What are the 4 things they believe AI will do for the hospital? And then we can bring that back into the curriculum. Our cohorts, our hospital-based cohorts range from 150 to around 400 employees. So if you start to bring that culture and what you stand behind with AI into the classroom, it makes it a much more smoother transition and has a more positive impact on culture when you start to introduce it, instead of it being something that's scary or something that's going to take a job away. Take the reins, understand what the top 4 things your hospital believes in, and bring that back into the classroom so you begin to graduate nurses who are already behind it.
Yeah, absolutely. It's so, in so many spaces, can be so easily unknown and then scary. So looking for ways to bring that in to the organization and how the organization works. I mean, we know it's happening in so many ways in our daily lives, whether it's our phones listening to us and doing things for us, sometimes correctly and sometimes not, but all the other options, and how can we use that to effectively support our frontline caregivers so that they don't become really, well-skilled typists, because I'm sure none of them went to school thinking, oh, what I want to do is type. As much fun as typing class might have been. All right, let me start again with Laura, with you on some of what would you sort of put on your list as which of the, of all the efforts, all of the things that you've been doing at Advocate to move the workforce recovery forward, what are like 1 or 2 of what you call the most successful, and can you describe them a little bit?
Oh, that's such a good question, because I don't know if there's one size fits all. I just mentioned being flexible. I think flexible is key, involving your teammates, your leaders, right in whatever you're doing. I think anything that you involve them from the very beginning is going to be more successful. I guess I'll just say probably one of our most successful was something called the Best Fit program, where you really hire your talent for your organization and then you allow them opportunities. We do that a little bit with the manager relief too, because they're able to see multiple different areas. And sometimes they find a home throughout that, and that's okay too. Being okay with being nimble and saying, yes, it's okay that you're finding a home here. In fact, we hire you for our organization. So I'll just say, being open-minded with that and bringing your teammates along. I know it sounds a little cliche, but truly from the day one where you're doing any new initiative, if you have them there, it's going to be more successful.
And actually, we've gotten a question about the virtual RN program for admissions and discharges. I know you guys do that. Can you talk a little bit about it?
Yeah, I'd be happy to. So we have virtual nursing in 38 of our hospitals. We actually have virtual sitting in 68 hospitals, but 38 are virtual nursing. Admissions and discharges where they follow the electronic health record. They remote in from behind a camera. We do have 3 central hubs in which that we support the nurses that are remoting in. It's non-recorded. Where they're fully integrated with the bedside clinician in a care delivery model. They're partnering using secure chat and also different algorithms that we have, of course, to recognize early deterioration and so on. But it is very widespread and scaled throughout Advocate Health.
That's awesome. I know one of the applications that I just think is brilliant is the fact that you can start admission while someone's still in the ER rather than waiting for them to get to the floor.
We do, and I'll just add, Elisa, that admissions are great. Certainly it's helpful to the nurse, but if you can focus on discharge and prioritize where you have capacity, you're going to solve for some of those bottlenecks to be able to partner with that bedside clinician. And it's not certainly very easy to tell and the nurse at the bedside that you're going to help do that, because our nurses love these patients. They want to see them out the door, but as soon as you can start to prove that trust with your clinicians, certainly it's more successful that way as well.
Yeah, absolutely. I'm sure all of the nurses eventually get to the point where they're like, oh, an uninterrupted discharge from beginning to end, answering every question the patient had. And I see my 2 nurses smiling because they're just like, yeah, that has not happened in, my experience. But I love that that's another benefit that I don't think anybody thought about when they were thinking about virtual nursing, but giving that space to someone to just do that and not have to manage multiple things that are going on at the same time. Rachel, your top thing.
Oh, I think our secret sauce is our leadership structure that I mentioned earlier. And so we have nurse managers, assistant nurse managers, a clinical advisor, partnered with a CNS and a nursing professional development specialist on each of our units. And some share units, like our bigger units, they might just have one assistant manager that report to a manager that has 2 of those departments. But we have really found a lot of success, and we're still reaping the benefits of that change from last year. And so what we're seeing is increased engagement of our team members through our Gallup scores and participation, increased retention on our units. And then we also saw a sharp decrease in some of our harms related work. And primarily that's because of the accountability, and someone's keeping an eye on those metrics, where we know in previous, when we just had a nurse manager, maybe a shift coordinator that was very shiftly, not out of staffing all the time, it was hard to keep an eye on all those metrics. And so I really believe that at IU Health West, our nursing structure, leadership structure, has been a key to our success.
Awesome. All right, let me ask Caitlin, what are you seeing as some of the efforts, nationally, a couple of things that you think are really making a difference in organizations that you're working with to really address some of these opportunities to both keep and mentor new folks into their organization?
Sure. Some of which I spoke about already, with just looking across the entire organization and then out 5 years, 10 years, and being really intentional. So when I think about some of the things our partners are doing, they're sitting down and they're really understanding turnover, retirements, growth, and promotions that are going on inside of nursing, but by unit. But then they really set benchmarks for themselves 1, 2, 3, 5 years out on what they want that to look like, as far as where staffing is coming from. What is their actual clinic when they have clinical rotations going through the hospital? How many get hired? What is their goal for travelers to bring that down? And starting to really solve their own problems locally and have their nursing team reflective of the patients they serve. Our partners, I always say the hospital is the hero in the programs that we're doing, because what they pour back into their employees really shows, because they now have a staffing plan that is 5 years, 6 years, 7 years out with their own employees, which is incredible, in a big nod to their commitment to workforce planning long term.
Really Great, thank you. All right, Laura, I'm going to come to you with this question, which I think is one that we have to spend a little more time on as a field in general, because what was traditional that someone would come and work in a hospital or a health system and be there for 40 years and then retire is no longer the case. I mean, we have a lot more movement across every industry. It's not just healthcare, but people change jobs. They move from place to place. They're more mobile than they used to be. So how are you using some of this work that you're doing to really instill a culture and keep a culture? Because you both are I know each organization, very protective of your culture and what that means for how you provide care. But how do you do that with a team that's more fluid than it used to be? Let's put it that way.
That's such a good question. I think really creating the culture in a psychological safe environment has to be your focus. You know, certainly all of the things we've talked about today are really important, but if you don't look to your communities and your culture first, I think you're going to be off track. You know, leaning into your boards locally, your schools locally, you know, your government, like you really have to immerse outside your walls in order to really secure and sustain your workforce. And then I'll just add, you know, your leaders need to be with their teams. We need to be with our teammates. We need to engage professional governance from the beginning and embed it into the fabric that we weave. I think that if we don't do that, you know, we're doing it a disservice. And certainly it's not a one size fits all for any organization, but really creating that culture beyond our walls of any healthcare organization. I mean, we're an example of that here today, coming together from other organizations, you know, hospitals, healthcare networks, et cetera. And I think it's really important that we keep the conversation going.
Absolutely. Rachel, how do you make sure that the culture is still the way everyone thinks it is?
Yeah, I think it starts with onboarding and making sure that we are setting that expectation for the new team members coming on, whatever their discipline, not just nursing. I think setting that expectation. I think we also do really well at IU Health is any recognition that we do, we tie it back to one of our core values. And so, you know, you exuded excellence today because of your teamwork. So excellence and team are two of our values. And we make sure that that is embedded in our recognition practices, in our accountability as well, in our tough conversations. But primarily, like, we have a great recognition platform and you have to select which one it was. And so I think that's important. I think also same with Laura, like we have to be out there, managers need to be out there with the people, you know, to not only have that connection and collaboration, but taking a survey of are we preaching or are we practicing what we preach? And that's really important to have those coaching conversations early on before you see it infiltrate your departments or your hospital. And so it's tough, but I think it is one of the most important things that we have to do as leaders, especially because anything that comes after that, if you have a sick culture, you're not going to be able to innovate. You're not going to be able to have that trust. You're not going to be able to say, hey, we're going to try virtual nursing and this is how we're going to embed it into our practice. Let's try it. You know, if you've got a very trusting environment, you've got a team that's like, yes, let's go, let's try it. If you don't, then there's going to be a lot of resistance to that change and perhaps it won't even lift off the ground. So culture is number one. And we definitely practice that a lot at IU Health West.
That's awesome. Yeah, I have a slide I use quite often, that culture eats strategy for lunch. And what I have behind culture is infrastructure. And you both talked about your leadership structure, how you've organized a lot of the different pipeline opportunities and all the different programs. And I think those really feed to, and Caitlin, you talked about it as well, the importance of having not only reinforcing the culture and doing that leadership work, but then having that structure behind you that is holding up all of the great work that you're doing as leaders. So I really love the way that you both describe that work. We have actually an excellent question in the chat that I'm going to, Caitlin, start with you to see from a national level, and then I'll go to Laura and then Rachel. Are there any metrics or data points, particularly outside of sort of the usual vacancy, turnover, retention, that you're finding helpful to pinpoint specific issues impacting workforce availability? Are there things that you are looking at and saying, you know, this is great, but then also, I don't know, high school graduation rates are also impacting, I made that one up, please don't take that as an actual one, are the things you keep an eye on?
A lot of them want to be nurses, by the way, though, Lisa. So coming out of high school. Yes. So, I mean, kind of going off the culture piece and my comment earlier about the right to the right of graduation and the left of graduation. So before graduation is the whole program, right? For a BSN program, that's 3 years. We are seeing that pairing our team with the hospital team and us being an extension of them, we have shared accountability for KPIs across the board. So for schools, what we care about and what we look at are like term over term persistence of students in the program. Are they progressing the way we want them to progress? Are they retaining? Are they graduating at above benchmarks nationally? Are they passing their board exams within 30 days of graduation? Are they onboarding in a way that is how the hospital expects them to timeline wise and integrating into the workforce in the way we'd expect? And some of that shared governance, I think, is really important because then we can begin to have conversations if things are going right or things are going wrong. So sitting down with your local schools that you work with and sharing what your onboarding metrics are and what you look at and what's going right and wrong and how can you back that in to the curriculum. So I think starting to bridge the two together is really important, that schools need to start, need to understand what your human resources metrics are, but for hospitals to also then understand the school's metrics and start to have conversations about those. One of the things that I notice is clinical to hire. Schools track that. So how many clinical rotations do they have and how many are hired then into that place where they did their clinical? Hospitals sometimes measure that, sometimes they don't. Sometimes it sits in an education department, but not in a human resources department. So I think starting to bridge those is just really important.
Yeah, I can see the need to make that a more of a continuum from education to practice. Laura.
Yeah, this is such a good question because data tells the story. In terms of everything we do, I will echo what Caitlin said, certainly university acceptance rates, but also clinical acceptance rates, because sometimes they get them in a program, but then when they go to apply for clinicals or their practicum experience, maybe they don't have a seat. So really keeping a pulse on that, what those rates look like. Nurse residency completion rates is another one that we actually code as a new grad in our job codes. So we in particular can get that data point. It's really important to not only our nursing education team, but also a nursing ops. Our board, certainly our RN board completion rates and pass rates. But then I'm going to put another spin on this. I think your financial data is really important. It does tell you a story of your burnout. So your no lunches, your incremental overtime, you can see where those hotspots are based on the utilization. And then of course your traditional engagement, your teammate engagement domains. We at Advocate Health also poll not only on a new hire, they get a survey. We get a survey on every year on your anniversary month, you get a survey. And then of course we have our annual engagement survey. And those are really important to put your ear to the ground to make sure you're listening, but don't overlook your financials. Sometimes there's data in there that's really important.
Oh, I think sound advice. I know the AONL CEO often says that the CFO should be her best friend, and they really need to work very closely together. So certainly seek out your CFO. Rachel.
Yeah, this was a very good question. And I was sitting here writing notes on like, what is it? Because I know we track and trend everything, right? We have data at our fingertips. It's almost overwhelming sometimes. To add some on to what Laura said, some of the things that we're looking at is how many times our leaders go to recruitment events, because we found early on that sometimes, you know, the leader, the people at the table for who's advertising for nursing roles aren't always nurses. And so we want to make sure that we're there to help answer any questions. It's easy for us to talk up our units. So that is helpful to say like, oh, I have a perfect unit for you if you live on this side of town and whatever, and make those connections pretty quickly. And so that is one of our measurements that we are monitoring over time to see how we're closing the gap on vacancy. And then Laura, when you mentioned something about being friends with your finance, I think that's super important too, because as we become more and more creative, and a question I often get, and it might be popped up in the Q&A section here when I talk about the leadership structure, is like, well, how are you doing that? I think you got to be creative with your vacancy. And so working with your director of finance or your CFO to say, hey, help me understand how I can make this, you know, FTE neutral, but then also, you know, budget neutral with the actual like dollar amount. And so that's how we've been able to create some of these positions to say, okay, I'm going to borrow here from my vacancy, but there's enough vacancy, right? And I remember going to an AONL conference, and a nursing leader said that, and I was like, oh my gosh, that opened my eyes for whatever reason. How she said it made me think like, duh, like it made sense. But I think that's really important to monitor your vacancy and what you can do with that vacancy.
Yeah, absolutely. Thinking outside the box is something I know most nurses know how to do, I feel like innately, because they have to address whatever problem they find in front of them. But I love the idea of just thinking about how can you partner, again, back to our theme of partnering across the organization and saying, hey, help me to think through, I had X structure, I now need to be able to make it a lot more fluid. What are some of the roles I can create? So to that end, let me ask the last question that I have. I know we've been going through the questions as we've been going. I don't think there are any new ones. But the last question I have, which I'll ask of all of you, like, either you can give me either some best practices, you've shared a number of them, or some advice on how you would tell someone else, you know, to address some of the local workforce challenges that they're facing. And I'm going to pick on Laura to go first. Apologies, I didn't start with your name.
No, that's okay, Lisa. You know, I think that your structure, you know, Rachel, you said it. I'm going to just double down on that. Your people are the most important. So when you're building anything, getting the right structure in place and then putting your people in place is going to help your culture. It's going to help your workforce challenges. And then I'm just going to say, be really creative. Don't let what you have hired into your organization be the only thing you're looking at to tap into how you can reinvent the care delivery model in the workforce needs at your organization.
Rachel?
Yeah, I think one thing that hasn't been mentioned that I think is a good nugget of information too is how do we engage the high school students who have interests? And in Indiana, so forgive me if this is a common term, but we use Area 31 as our pipeline to engage high school students who are interested in a healthcare profession. It doesn't have to be nursing, but we bring them into our environment and give them, you know, a paid job. Now there's some nuance with it, hiring a minor, so definitely partner with your HR colleagues on that. But we have found huge success that they're super interested. We've had several as they graduate high school go to nursing school and stay on with us as a PRN PCA. They can't do all the tasks of a PCA because they are minors, but that's really important to build that relationship. And it's a great way for your organization to build relationships with your local schools. And also going to career fairs frequently, so that way we are promoting our profession in a positive light, to make sure that we continue having students who are interested in our profession.
And Caitlin, I'm going to give you the last word here. What are some of the things you see nationally that really are helping to move this forward?
Yeah, I mean, Everyone's giving such good advice. I think the theme with partnerships and breaking down silos within our organizations and even outside within our community is key. So if you haven't sat down and actually, I know it sounds silly, but just to sit down and truly map out the problems, I think that's step one, and to do that across the board, not just within nursing, and to pull in a partner in finance, as Laura and Rachel have mentioned. That's really important. And if you don't map it out first and look at it from a large eagle's eye perspective, it's a lot harder to back into creative solutions, and you feel like you're spinning your wheels a bit. So that would be my advice.
Absolutely. And you can't quite see it behind me, but there is a giant whiteboard here. And anyone who comes into my office with a problem usually gets handed a marker. Okay, draw it out. Let's talk about it. So I love that advice. With that, I think we've gone through just about all of the questions. We will follow up if there are some specific ones, but thank you, all of you, for your insights, sharing your time with us, all of the work that you do both locally and then the work that you commit to do in partnership with AHA and AONL to spread and share this. And a huge thank you to Caitlin and the team at Unitek for sponsoring this work and continuing to help us bring more people into nursing and all the health professions. With that, I will give everyone a couple minutes back to their day, and thank you again for joining us. We're adjourned.
Thank you.
Everyone.